Check, check, check. Check 1, 2. 1, 2. Check 1, 2, 3. Check, check, check. Check 1, 2. Check, check.
Nice way to start.
Good morning, everyone. Welcome to Grand Rounds. I'm Nancy Harper. I'm the Child Abuse Pediatrician and Director of the Otto Bremer Trust Center for Safe and Healthy Children, and we are super pleased to be able to host Grand Rounds this morning. Our speaker is Dr. Brooks Keeshin from the University of Utah. He is what I call that quadruple threat. I'm super impressed when I meet people with the number of certifications that he has. He is a pediatrician. He's also a psychiatrist, child and adolescent psychiatrist, and a child abuse pediatrician. He has many leadership roles that surround violence and trauma in children. He serves on the board of directors for the Academy on Violence and Abuse. He's also on the American Academy of Child and Adolescent Psychiatry Committee on Maltreatment and Violence. And he's also the director at his institution of a SAMHSA-funded Category 2 Center of the National Child Traumatic Stress Network. So we welcome him this morning. I hope you find his talk today helpful, and he's going to speak on pediatric traumatic stress, a practical approach. Thank you.
Good morning. Good morning. Can you hear me back there? Okay, great. So I have a lot of content to go through today, so I'm going to try to jump right to it. These are disclosures. Again, as Nancy mentioned, we get funding from SAMHSA, along with the Utah Department of Health, Hunter College, and Uppsala. And I do receive royalties from UpToDate. And I have the privilege today to talk about some of the work we've been doing in Utah. And this is just a highlight, because I don't want to have the acknowledgement slide at the end when there isn't time and I've gone over and all that kind of stuff. But this is really the work of, about a half dozen really key folks who are involved in this work, but then really dozens of partners throughout the state and actually the country. And so really appreciate the chance to come out here and share some of our work with you all. And in a lot of ways, what I want to kind of highlight is that our work in terms of identifying and responding to traumatic stress in pediatric settings, it's really born out of a clinical question. That clinical question is, how do we know which kids are the right kids for trauma treatment, for evidence-based trauma therapy? And it's a question that, we did a lot of work over the last 20 years in terms of developing evidence-based trauma treatment, but we never did a ton of work to figure out how do we identify those kids who might not already be in therapy or already linked into the system? How do we know which kids need to go and receive trauma treatment, or at least be evaluated? And this is an example of a young lady who one of our project manager was the lead therapist for. And this is not an uncommon scenario. She was receiving evidence-based trauma treatment in our center. It was trauma-focused cognitive behavioral therapy. And her story isn't that much different than anybody else's. She had remote history of sexual abuse. And when you kind of plotted her life experience, again, nothing that remarkable. She was sexually abused before the age of 7. She recognized retrospectively that she had been sexually abused around the time of entering into puberty. She started to have a lot of high-risk behaviors, a lot of difficulties in school, but she didn't disclose until she was 15. And even after disclosing, she still didn't make it for therapy for another year. And I think the main question is, could her pathway have been different? Could we have responded as a healthcare system differently so that she either would have had access to treatment sooner, maybe even initiated a realization of what happened to her sooner, or could we have at least not waited until kind of the wheels fell off the bus and school was a problem and friends were a problem and family was a problem? And that really is kind of what drives us today, and I hope to be able to make an argument to you all that I think we can, and I think we're getting there. So I would like to divvy up the talk today into a couple of sections. One is kind of first addressing this issue of ACEs, or social determinants of health, and trauma, and how they're different. Because I think oftentimes we kind of conflate the two a little bit, and they're both really important, but it's also important to differentiate them. Another is talking about trauma course, just to make sure that we're all on the same page as to what we're talking about for traumatic stress symptoms. And then last, identifications and treatments. So trauma versus social determinants of health. Well, those of you familiar with kind of the idea of toxic stress in pediatrics, it's become something that's really been talked about a lot over the last 5 years. You know, I think a lot of folks, when we started doing our work in identifying traumatic stress, they said, oh, well, you know, toxic stress, that's really good to identify. And the reality is that they're actually two very different things. The toxic stress does have a theoretical framework, but in a lot of ways, when you identify a child at risk for toxic stress, you're doing more risk stratification. You're recognizing that child's more at risk for a number of different things. Whereas when we're talking about traumatic stress, we're talking about actual, very clear physiologic reactions that are predictable, that we understand, and that actually derive a specific type of treatment. And so if you look at this article from Pediatrics back in 2013, Johnson and colleagues described how kind of toxic stress is really important for pediatricians to know about. It's a stressor. The child is not able to effectively recover from that stressor, and it really essentially impacts the entire body. But we don't necessarily have Band-Aids for all of the things that toxic stress itself causes. We have treatments for the different things that children are at higher risk for when they've experienced toxic stress. But just knowing that they have toxic stress, it doesn't actually tell you the treatment plan. In contrast with traumatic stress, there is a grounding, albeit not the best grounding. I think there's a lot of things to quibble about with DSM-5, although it's better than DSM-4. But at least it gives a diagnostic grounding, a treatment plan grounding of what we're going to do moving forward. And it's not just about PTSD. PTSD or traumatic stress is linked to lots of other disorders, including depression, anxiety, and ADHD seen in kids. And it answers questions like, what do we do now? What do we do next? And what are we going to follow? Additionally, there's a lot of guidance for our different academic societies, including AAP and ACAP, on how to proceed with traumatic stress. What are the evidence-based guidelines for the treatment? How do we encourage the overall surveillance of this population? And I do want to put in a little plug. Hopefully coming this fall, there'll be a clinical report in Pediatrics talking about the evaluation and treatment of maltreated children, which is essentially going to be focusing on how do you address traumatic stress in a pediatric setting. So a little bit on trauma course. So where I want to start with is not getting into totally the weeds of PTSD and the diagnostic criteria, although I will allude to that some. But when we kind of took a whiteboard and thought about, well, what are the important things to think about after a child's experienced some type of traumatic event or potentially traumatic event? What are all the things that we need to think about? And we wrote tons of stuff on the board, and we then spent the next year, frankly, culling things off because there was too much. There was too much there to be really practical, feasible within a pediatric setting. And eventually we distilled it down into what was eventually three main things. One is additional trauma experiences and adversities. We know that kids and families who have a traumatic experience, unfortunately, are more likely to have other traumatic experiences or have secondary adversities related to their trauma. Secondly, suicidality. Suicidality is not limited to depression. Unfortunately, it's really aligned with more distress, of which traumatic stress can be a huge driver for suicidality. And to create something that kind of skipped over suicidality seemed to be disingenuous, frankly, when we're talking about kind of teenagers especially who are at risk for suicide. And then, of course, traumatic stress symptoms. And kind of to think about that, so here are the types of traumatic experiences that we talk about for PTSD. So direct experience or seeing it or having a loved one happen to it, having a loved one have that happen to them. But then in terms of the traumatic stress symptoms, I think one of the barriers for many folks who don't do PTSD on a regular basis is, you look at this list and it seems like it's all over the place. And I'd like to kind of walk through how I talk to families about that, because if we try to distill into something that's a little simpler and makes a little bit more sense, I think it becomes a little less burdensome to try to tackle. So if we acknowledge the fact that about 80% of children will have a potentially traumatic experience sometime during childhood, so that's that first criteria, that having had some type of potentially traumatic experience. I like to think of the intrusive symptoms as being really the core PTSD symptom. And that's those symptoms of trauma, those symptoms being associated with either memories or flashbacks or nightmares associated with the trauma, or physiologic or psychological distress related to trauma reminders. It's a core symptom. If what happened to you continues to be bothersome to you, even when you don't want to think about it, or something unfortunately reminds you of it, that's an intrusive symptom. And essentially all the other symptoms we talk about with traumatic stress really do fall from that. So if you're continuing to be bothered by what happened to you, it actually makes sense that you would try to avoid people or places that remind you what happened. You try to avoid thinking or talking about the event. I don't look at that as another symptom. I look at that as a normal, understandable response to that first core intrusive symptom. If you continue to be bothered by the negative things that happened, it makes sense that you kind of check out a little bit or see the world as a dangerous place or not have connections and feel detached from other people. These negative cognitions, these negative thoughts or negative moods, if you're ongoing bothered by that past experience, this makes sense. And of course, if you continue to be bothered by those bad things that happened, this idea that you'd be on edge, looking out for danger, ready for the next bad thing to occur, again, that makes sense. If you're looking out for danger, you don't go to sleep. Like, that's just normal. That's a normal response. And of course, for some individuals, not everybody, but some, when they get really activated, when they get really aroused, they actually zone out. They go away, they kind of aren't part of their body anymore, they're not part of the world anymore. Some folks do that, some folks don't. But again, that's a normal, natural response. It's that deer when the mountain lion comes out and just freezes. That's the freeze part. Some do it, some don't. And we do recognize that children are certainly not all just short adults. So we do recognize that there are some things that are slightly different than them. For example, one of the criterion A is that as a professional, like all of us, if we're caring for folks who have experienced some type of traumatic event, we ourselves are actually at risk for developing traumatic stress. That's a criteria that we don't include for kids because we assume that 7-year-olds shouldn't be working. So that's at least in Utah. I don't know about Minnesota. When it comes to the criterion C and the criterion D, the avoidance and the negative mood, we recognize that some kids, especially younger kids, don't make the cognitive connection, and so therefore aren't that good at avoiding. Like, it's the whole, the stove's hot, ouch, don't touch the stove, ouch, don't touch the stove, ouch. They don't make that connection as well, and certainly can't always formalize some of their negative thoughts of the world. And the reckless and self-destructive behavior, we don't really include that as part of the criteria for little kids, not because it isn't true, but because it doesn't distinguish. Essentially, reckless and self-destructive behavior is part of the chief complaint for almost every referral to a behavioral specialist if you're under the age of 7. And the one thing that we do switch out is that instead of detachment, we do think about withdrawal symptoms because that's something that's observable. And I'll admit that I am, guilty of asking a 5-year-old whether or not they feel detached. You don't get a very reliable answer. So it's not just about symptoms, though. It's also part of a time course. And Chris Lane, who's done a lot of great thinking about kind of trauma and PTSD and trauma caravans, I'm borrowing from his work because I think he does lay out really nicely some of the complexity of it's not just that experience, but there's different ways of kind of having your own unique pathway forward. And so the first one is resistance. You can see that at the bottom. And just to kind of orient you from the graph, the y-axis, it's just functioning. So top is good, bottom is bad, and then we're talking before the trauma, during the trauma, and after the trauma along the x-axis. So with resistance, there's really no appreciable effect of having a potentially traumatic experience. It's having something that could have been really scary, might have affected someone else, and really just doesn't impact you at all. The key is that this is resistance, not resilience. Resilience, which is something that I think we are very comfortable talking about in pediatrics, there is an appreciable impact. And it's important to differentiate the two because, I think sometimes we can see a kid who is impacted by what happened to them, and we might think, oh, that's not necessarily a resilient family. And that might not be the case. They might actually be very resilient, and they're going to bounce back up, or we could support them bouncing back up really quickly. But the fact that they've had an emotional or functional impact related to their exposure, that doesn't mean that they're not resilient. It means they're not resistant. In the clinical setting that we have, the case that I shared with you at the very beginning, Delaney, she was a good example of decline. A kid who has an experience, it looks like resistance, which gives us a false sense of security that everything is okay. Or in her case, there was no disclosure, so we didn't even know to be vigilant about something not being okay. But then years later, there's a decline. And the challenge with these is that you can also get into the sense of, oh, well, I know that she was sexually abused back when she was a little kid, but that was like 8 years ago. So it couldn't possibly be related to that, when in fact, oftentimes it is. Protracted recovery, this is what we often experience in our trauma clinics. That's why kids come to us, is that they do poorly, they eventually get into therapy, and we help kind of get them better. Slower and longer time with poor functioning, and so as you'd expect, it takes a little longer to get back to normal. Unfortunately, some kids do end up more like this graph, which is they might get into therapy, or some things at home might kind of help things improve a little bit, but they don't get back to where they were supposed to be. They establish a new functional baseline, which is lower than the one before. This is the one that keeps me up at night, frankly, because families can get into therapy, they'll come for a few sessions, or they'll get some help and services, but instead of advocating and saying, I want my kid to get right back to where she was before, they get a little bit of improvement, or the kid gets a little improvement and says, that's good enough, and then they're off, and essentially we've taken a kid who was doing great, and now, she or he is doing okay. And I think that's a failure of the system in terms of not getting kids back to where they were before. Post-traumatic growth is a wonderful thing. I don't know how to do it. I've seen other people who have experienced this, and I've been able to be along for the ride, essentially. But trauma therapy isn't about making kids better than they were before the traumatic experience. It's about getting them back to where they were before. So, if you all have the secret sauce for this, I think you should bottle it and sell it around the country. And then lastly, stable maladaptive functioning. This is one where I think, we see kids who come from lots of challenges and difficulties. Something bad happens, and it's similar to resistance. You can't find an appreciable change, but the reality is that because they're so close to the floor already in terms of their level of functioning. And I think these can be difficult ones to tease out. What are we looking for? What are we going to do next? Because it's not just trauma treatment they need lots of support. So this is the context. We have a disorder that is kind of grounded in intrusive symptoms, and then lots of other things that naturally follow it. And it's got, a number of fairly predictable courses that can take. And if you're thinking about in a pediatric setting, whether it's a child abuse pediatric setting or a general pediatric setting, we can have a known traumatic experience, and then all we have to do is figure out kind of what pathway they're going to. That's simple. You could do that in your 11-minute visit, right? I mean, that's pretty straightforward. And especially if you realize that through the trauma caravans, the trauma exposure caravans, adversity begets adversity. And so it's usually not just one trauma, it's multiple traumas. And then you add in all the little traumas on top of that. And, and this is why people don't want to do this. Because, you look at this and I know that if I find this kid in my primary care clinic, my day is shot. The schedule is over, I'm going to be backlogged by an hour. I don't want to get into this. And you can recognize why that would be the case. But I'm going to suggest we can. So how do we identify and what are the treatments out there? So I'd like to get a little bit into our project. We are a Category 2 center of the National Child Traumatic Stress Network. That's a network that's funded by SAMHSA. It's been around for about 18 years now, and it was essentially designed to be a learning network model that is not healthcare focused, but includes healthcare as one of the members on the table at the table. But essentially, it wanted to kind of explore and figure out what are all the different sectors that come in contact with potentially traumatized kids, and how do we improve the response of these sectors for those kids? And so there's centers that are focused on education, young children, families, residential centers, treatment centers, and there's a few of us that are focused on medical-like settings. But we're a minority within the group. And there we are, for those of you who don't know. There's Utah. When I went there for my residency interview, I didn't know where Utah was because I'm from Cincinnati, so I flew there, and but that's it. It's a lovely place, and this is who we're working with. So that's a picture of the Wasatch Mountains behind the University Center. The Wasatch Mountains really are just right behind. You can leave the parking lot at the Huntsman Cancer Institute and just go hiking in the foothills. The parking lot is a trailhead, essentially. So we are right there. And we're fortunate to have a number of partners because we recognize that if you wanted to figure out how do you increase the pipeline, how do you make it more efficient to detect and refer kids for traumatic stress, you can't do it by yourself. And so we have the fortune, we're the University of Utah. We work very collaboratively with Intermountain Healthcare. But we also develop relationships that we fostered over the years with the Utah Office of the Attorney General, because they oversee all of our statewide children's justice centers. In Utah, we call them justice centers, not advocacy centers. We're about justice in Utah. But we have about 22 of these CACs or CJCs across the state. We work collaboratively with the Utah Office of Victims of Crime, because they're the folks that administer VOCA. They are one of the largest payers of services for victims of crime in the state of Utah. So if you don't work with them, you don't bring them to the table, you're kind of creating something, but you don't have the payer involved. Same with Select Health Insurance. They insure about 60-ish% of the state of Utah. So we worked really closely with them to figure out, well, how do we do this? How do we make sure that we're going to be able to serve these kids right? And then we have a lot of partners, both within and outside the NCTSN as well. And our goal was to take something that Intermountain does pretty well, which is these care process models. And lots of places will call them different things, clinical guidelines, care pathways. But in Utah, they're called care process models. And essentially, it's that foundational idea that if you standardize your processes, you improve efficiency, you increase accuracy, and you decrease variation, all of which improves quality. And one of the things that Intermountain does well is that they deliver a very high quality healthcare product while not being that expensive. And that's kind of their pride. And so as a University of Utah faculty, who's actually faculty in the competing healthcare system in Utah, we actually in pediatrics work very collaboratively on kind of utilizing some of their models, but then applying more evidence-based research methods to study and hone them. But essentially, that's the strategy. And what we did is we wanted to do this with pediatric traumatic stress. And so this is our initial roadmap. We're literally revising it this week. So we've been doing our pilot work for about a year, and I'll share the data from that pilot with you all. But essentially, we wanted to streamline traumatic stress to the way that in a frontline pediatric setting, whether it's high-risk folks like a child abuse center, or whether it's more low-risk folks like a primary care clinic, or any number of types of settings in between, foster care settings, specialty pediatric clinics, emergency department, frontline pediatric settings, that we could develop a tool that would actually be agile enough and malleable enough to work in any of those settings. We didn't want to have a primary care tool and a CAC tool and a foster care tool. We wanted to have one tool that would work wherever children encounter primary pediatrics and are at risk for traumatic stress. But there are a lot of practical issues to consider, and so this is one of them, the low prevalence versus the high prevalence. And, it's interesting when you go around and talk about, what's the point? Both the low prevalence and the high prevalence folks have things to complain about, which I didn't actually realize until we started this. The low prevalence ones I understood, like, oh, well, trauma doesn't happen to our kids. It happens to Nancy's kids. I mean, Nancy's kids have lots of trauma, but not my kids. So why should I spend all this time and resources into looking for kids that, really, I would know it if I saw it. And then when I would talk to not Nancy, but some of Nancy's colleagues within child abuse, I would get the opposite response. Well, they're all traumatized. Like, there's no point in screening because they're all traumatized, and we have to do something for all of them. Again, that same thing of, well, the data doesn't necessarily support that, and, how do we most effectively use our resources? At least in Utah, we don't actually have enough evidence-based, trauma-trained child therapists for every single child in the state. We don't. Do you all have that here? Yes? Well, maybe. Maybe you actually do. I don't know. But in our state, we don't. We have to actually be thoughtful about which are the kids who need a trauma assessment and treatment, because we will never have the resources, just like we don't have an ICU bed for every child in the state. We hope that only a few kids in the state will need ICU beds at any given time. And the same thing is true for trauma therapy. Other issues to consider, do we want to do this as screening or case finding? And, I'm not going to tell you that we have the perfect answer for this, but the work that we've done is to look to see, can we feasibly do this from a screening standpoint? With the idea being that if someone chose not to do this as screening, but more case finding, and I'll highlight a rationale for doing that in a few minutes, that it would also be feasible as well. But for us, if we could make this work as a screening tool, a universal screening tool, that was kind of our goal. It had to be that simple and straightforward. And also it has to be relevant to clinical decisions that we might make with the family right then and now. It can't be something that's nice to do. It's good to know. I'll feel better knowing that I've done it. It certainly isn't something that's going to be kind of some CMS or some other clinical requirement. That's not going to come down the line for a long time. But it has to make it has to moderate a clinical decision you're going to make right now. And so beyond just trauma treatment, it also impacts things like medications and when we're going to be using meds. And I'm going to get to those slides in just a second to show you kind of what I mean. So if it is trauma, what do we do? Trauma-focused therapies are really the cornerstone of trauma treatment. That's in contrast to this. You want to take your phone out, take a picture of the slide, so you can remember it for later. These are all the medicines. For the trainees in the room, this is like my favorite slide, right? Okay, I can remember this. But it makes a huge difference. Whereas there are lots of treatments, and I was talking with Nancy earlier, and you all are fortunate to have a lot of these types of things around. There are therapists who provide trauma-focused cognitive behavioral therapy in the area. It's not that these things are not accessible. It's that we need to know which kids need them. If we want to kind of distill what are the main components of trauma-focused therapies, I am going to use trauma-focused cognitive behavioral therapy as an example because they have a nice mnemonic. They developed a whole number of years ago, practice, to kind of talk about the different components of the therapy. And in a lot of ways, I think that this is still a little bit too complicated for me. So I like to think about it more in 3 different sections. And this is really true and transcends almost all of the kind of the trauma-focused therapies out there. The first section is thinking about kind of preparing and coping. So you want the family to understand how his or her body is responding after the traumatic experience, to recognize that this is not a weird or strange thing, this is actually pretty common, and that there are things that the child and the family can do already right now to start to help and calm some of that distress. So we want to get them moving in the right direction, but we're not flooding them. We're not kind of throwing all the trauma stuff back at them right away. We're giving them skills and giving them understanding. Once they're at a point where they do have that understanding and they can demonstrably use those skills, then we talk about exposure and processing. And really, it's both those things. It's not just kind of gently exposing the child to what happened to them in trauma-focused CBT. It's through the use of a narrative where they write the story themselves. But it's also in identifying thinking errors that kids commonly have. And as they tell the story, they highlight those thinking errors, those challenges, if I hadn't gone on a date with him, he wouldn't have raped me. That's a thinking error because it attributes the fault of the rape not to the assailant, but to the victim. It's my fault that this happened. Those types of thought errors, if you're not telling a story, if you're not going back there, you don't necessarily uncover them. And it's both in correcting those thinking errors along with the exposure that are both really critical to making it so that those bad things that happened before, that they're not in control over the kid, but rather instead the kid is now in control over the memories. And then lastly, another really important piece of trauma-focused therapies is it doesn't go through college. Like, we're not trying to set the kid up with a therapist and have them go to the therapist for, 7, 8, 9 years, weekly for essentially forever. There's an end to it. And the end is where the child tells the story or relates their experience to the parent. And the parent reestablishes their role as the individual providing the safety and emotional stability for the child. So there's a beginning, middle, and end. Trauma-focused CBT generally lasts somewhere between 16 and 24 sessions, so it's not that long. And that's pretty comparable with a lot of the other modalities out there. So it's very doable, it's very accessible, but how do we get kids there? So in our model, we talked about, and I'm going to run through our model pretty quickly to highlight some of the key features, and then we'll have some time for questions and comments. But these are those 3 things that I highlighted at the very beginning. So we need to know that something's happened. We need to know if the kid's suicidal. And we need to have data to make the right choice as to what to do next with this kid. Because it's not just one size fits all. So this is a mock-up of the form that we've used. We've been piloting this thousands of times in primary care and CAC, or child abuse settings. But essentially, the top part, there's a stem to ground, like, what are we even talking about? So in a language that's accessible to a parent, if they're filling this out for their 5 to 10-year-old, or for a child who's filling it out for herself or himself if she's 11 or older, it kind of grounds, like, what are we talking about? And then it asks 2 open-ended questions. Has something like this happened to you recently? Has something like this happened to you in the past? And it gives you the option to write something or not, but you don't have to. And then we have trauma symptom questions here. This is basically a modified version of the brief UCLA PTSD reaction index. So the full reaction index was actually just published back in November, December in the Orange Journal, validated tool to identify trauma symptoms consistent with PTSD. This is a brief version that's been developed based on the larger version and validated against the larger version. I think the publication for this one should be coming out pretty shortly. And then at the very bottom, we use the PHQ-9 question 9. Anybody else use the PHQ in clinical settings, the depression screener? A few? So essentially it's a 9-question screener. We use the same question 9 question. Essentially just do that in places that aren't doing depression screening. And that's our suicide screening question down at the bottom. So to kind of run through how we use this, this is something that can be filled out in the waiting room before the kid goes back for a visit, which, again, limits the amount of time that the clinician would spend on it. And for the beginning part, what we ask clinicians to do is to look at the top and the bottom first. Don't get sucked into the middle where all the kind of the cool stuff is, at least for a trauma person like me. I think of all the cool stuff. But look at the top and the bottom first, because that answers our 2 questions about safety, which is really, are they reporting something to us today that we need to just take a second, stop and listen? Do we need to think about, has this been reported? Do I need to call Nancy? Do I need to do something that, make sure that this kid is physically safe? And it might not just be child abuse. I mean, it could be something, a community violence, something else that might indicate the child is at risk for future safety. We don't want to do trauma treatment when the kid's really at risk. And then going to the bottom and looking at the suicide screening question, because we don't want to, again, move forward and come up with the world's best treatment plan ever, but skip over the idea that the child is suicidal. And for our suicide process, what we essentially do is we use a 2-step process, again, to streamline and make it as easy as possible in the primary care setting. But essentially, it's for any kid who's positive on a PHQ-9 question 9, within our system, we basically use the Columbia Suicide Severity Rating Scale. And this is a very easy to use 6-item questionnaire, but it's really an interview, although you can have a child fill it out. But it's nice because for most kids, essentially this Columbia here, you can, if you Google suicide prevention CPM, you can get the full version of this online. But essentially what this does is it gets you from passive suicidal ideation, kind of just wishing I was dead and not wanting to wake up, all the way through question 5, which is an active plan with intent to do something about it, or question 6, which is I may or may not have an intention to do something about it right now, but I did actually try to kill myself within the last week, the last month, last year. And essentially, it's a way to quickly identify what are the kids I need to be most worried about. I don't want to spend a ton of time, because I don't have a lot of time, on kids with kind of chronic passive suicidality. That's a kid who can let the parents know that they're still having those issues and make sure they have some resources and numbers, and that's probably good enough. A kid who actually has had thoughts about killing themselves and actually has an idea of how they might do it, but they don't have any plan or intent, that's a kid that still probably doesn't need to go to the emergency room. They probably can be effectively safety planned within a general setting. But knowing that small percentage of kids who do have an active intent and plan when screened, knowing which ones you need to get to either crisis or the ED, that's really critical. And you can see here our numbers, which this is the numbers when we first started. They really haven't changed. About 9% of kids having some concern for suicidality when they're teenagers, and we're using this in a primary care setting. About 2% having several days or more, so a higher risk within that screening question. But I think we've only had in over 1,000, almost 2,000 kids we've done this in different primary care settings. I think we've had like 1 or 2 that have ended up going to the emergency room. So again, not a ton of kids that need crisis, but a wonderful opportunity for education. So then what do we do once we know that the kid is safe physically and not suicidal? And this is where you quickly go through left to right and up to down. So thinking from left to right, if a kid has had a potentially traumatic experience and everything on the symptom score is fine, we can validate that and say, sounds like you all are doing well. Know that I'm a resource for you if things start to not go so well in the future. And that's it. Done. Done. If they're in the middle, now this is, again, not rocket science. The then it's kind of in the middle. And it's an opportunity to engage with the family and think, based on the exposure your child's had, based on kind of what you see with your child, are they going in the right direction, the wrong direction? What's the family supports in place? Maybe we do link you up with an evidence-based trauma therapist. Maybe we engage you with more kind of community-based mental health, or if you have mental health integration, maybe we bring the clinic therapist in for a couple of sessions. But really, it's an opportunity to kind of, engage in some shared decision making. But it's these high-risk kids that I think are the most critical. If you had a kid who is doing great in your clinic and their glucose was like 287, that's high, right? Okay. Yeah. I don't do a lot of gen peds, so I do want validation saying, yes, that is high. Okay, good. Even if the family said they were doing well, you would still treat their diabetes, right? I mean, you'd still do something at 287, fasting 287. It's the same way with this. If a kid is doing poorly and they have high symptoms, it's pretty easy to engage with that family and say, okay, well, it's great that we actually have something that's shown to treat kids just like your child after experiences that she's had. But when they think that they're doing well, this is really the critical tool, because kids who have these symptoms, one, most often these symptoms just don't go away on their own. And two, eventually it's going to take its toll on the kid. And so getting into therapy sooner is really a very preventative way of addressing these symptoms. But you have the data. You have the data to share with the family. You can engage with them and say, hey, it's great that she's still going to school, still keeping up with the classes, still doing soccer practice. That's wonderful. But this will take its toll after a while, and I think it's best that you do a trauma evaluation, at a minimum, and then kind of see where things go. And then the other thing that we've designed within this tool is that you can also look at it going from up to down, because sometimes people actually want to do something right there in clinic. And so we structured the questions and we designed them in such a way so that if you're going from top to down, it highlights what's the most critical thing, if you're going to do one thing today, that you could address. And the first thing is looking at that top part. Those first two questions, those are both about sleep. And in my preference, and I think there's a lot of kind of practical thinking behind this, is that if sleep's an issue, and if you don't address sleep, you can spend a lot of time addressing a lot of things, and it's not going to make a lick of difference because the kid's still not sleeping. And I do want to highlight that Nancy Harper is an upcoming guest editor for Pediatric Annals. So if you want more information about kind of how to address sleep in a trauma-focused way, we will have an article coming out this summer-ish, yes, on this topic. But essentially, you can kind of go back to what do you normally do with a child who's not sleeping well. And I think that's a good place to start. And you can often go back with the parents and say, what have you done in the past to help your child sleep, and encourage them to utilize those skills again. But if you need to go deeper, the article will go into this in greater detail of kind of identifying, are we talking about pre-sleep issues, during sleep issues, or kind of morning awakening challenges, and then highlighting some things that are a little bit more trauma specific. One of the ones that I'll just highlight very quickly is the negotiation piece. We find a lot of our families, proximity can actually significantly treat trauma-related sleep problems, because the child's separated from their parents, their trauma symptoms are heightened, they're not able to fall asleep. The parent comes into the room, the child's able to fall asleep. A lot of parents are resistant, though, to doing that because, I don't want them sleeping in my bed till they're 18 years old, or, I don't want to do this every single night for the next year. So thinking about, how do you do this as part of a negotiation? How do you engage with the child in a way to say, I recognize that, you're feeling a little distressed or upset now when you're trying to go to bed. I'm going to stay with you in the room, for the next week or two until your body kind of calms back to normal. But it's reestablishing that, it's negotiating that and saying, does that sound okay? Do you think that'll work? And we'll try this for the next couple of weeks. And our goal is to get you so that you're able to fall asleep by yourself like you used to. But it's setting that stage and thinking that through, but also addressing that real resistance that parents can have to engaging in something like that. If sleep's not an issue, but heightened arousal is, that intrusive symptoms and that hyperarousal are, those are kids that are way up here. We need to give them a skill to calm down. We need to give them a way to kind of bring themselves down, to bring them back to a calmer place. This is where things like belly breathing, guided imagery, progressive muscle relaxation, it can be your normal go-to thing. You don't have to be creative and have 47 different options at your disposal. I mean, I do belly breathing. If it's a younger kid, I pull out the Elmo belly breathing video and we play it together, and I have the song run through my head the whole rest of the day. Elmo belly breathe. If you've never heard it, Google it tonight. 2.5 minutes of your life. And it's actually more than that, because the song will also play in your head for days and days after that. But it's wonderful. And then if sleep's okay and arousal's okay, but they're really detached from the world, they're really thinking negatively about themselves, they may need therapy, but can we do something to help get them moving again? Can we do some just behavioral activation, maybe a little bit of increased encouragement and communication? Just let's start the process. It doesn't have to be the end all. It could be the beginning of the pathway for the kid. These are a couple of resources, including the PTSD coach. That's the Elmo Belly Breathe. It's a snapshot of the Elmo Belly Breathe video. The PTSD coach is designed for adults, but I do think that it works pretty well for adolescents. I wouldn't do it with a younger adolescent necessarily. It's not that exciting of an app, but the content is really good. And whether it's the adolescent doing it or the parent doing it and finding some of the skills, either can be helpful. And then, of course, you can use the same tool to follow them up and see, well, the things that we talked about 2 weeks ago, are they making a difference? Are we going in the right direction, wrong direction? Or do we need to talk about therapy? So just a couple of slides on kind of our progress in Utah. So this is, again, is our state. These are all the different counties, and these are all the places where we're piloting both in primary care as well as in children's justice centers. And I highlight this because although we do have pilots going in urban places like in Salt Lake and in Utah County where Provo is, most of our work and really a lot of our learning has been more in rural and even frontier areas. Because we didn't want to design something that's great if you're in a city with every resource at your disposal. And so part of our efforts have really been to focus on developing something that is malleable in both those environments. From a CJC or a CAC standpoint, as you would guess, and we have a very high completion rate because it's part of their process now at the CJCs. They're completing that. About half the kids have a high risk for PTSD, being a score of over 20 on the symptom measure. We also have high trauma symptoms associated with suicidality. So, one of the things that was really a wake-up call to the folks at the CJCs was they had no idea there was this much suicidality going on at their center. But at the same time, we talked about the Columbia and how to respond appropriately. And so we essentially empowered these settings to really kind of be able to address the great majority of the suicidality on their own, to the point where we really only have about 2 to 3% of our adolescents getting referred for crisis evaluation. Even though we're picking up about 40%, I think. It's not on the slide there, but it's about 40% of kids have some risk for suicidal ideation in this cohort. Which I think is pretty amazing, given the fact that most of our CJCs don't have mental health therapists available. These are life folks. These are victim advocates, paraprofessionals who are doing this. I think it highlights if you empower folks to address suicidality, they really can do it. But you do have to give them the tools, or else you're just gonna make them resistant and not want to go there. This is what we're doing at the CJC. So just for that sleep problems, this is data that we've shown. Like, you don't have to reinvent the wheel. About half the time when they identify sleep problems, they're doing belly breathing. About a third of the time, they're doing guided imagery. And I do have this one, because this is not something that we told them to do. This was something that a victim advocate suggested to a family. Maybe you should just stay in the room for a little bit and help the kid fall asleep. A normal, empathetic, kind of parent-to-parent suggestion, which, I also got to work with Bob Pynus, one of the pioneers in pediatric PTSD, and that was his suggestion too. So, it's something where if you empower families and empower settings to do the right thing, oftentimes they'll come up with wonderful things that we might not have imagined. In addition to this, we're getting about half of our kids into evidence-based trauma treatment utilizing this tool because it's an engagement tool. And we're actually working with the National Children's Alliance, which is the overseeing body for CACs across the country to make sure that this complies with their guidelines. So in primary care, I'm going to go through these pretty quickly to save time for questions. These are the numbers. This is the answer to the pediatricians who said, why should I spend so much time finding a needle in a haystack? I'd know it when I see it. This is primary care screening, coming in for just, sports physicals, ankle twist, and some for behavioral health care, because that's one of the reasons why people go to a pediatrician. 25% reporting some type of potential traumatic experience, self-report for adolescents, and 20% with the younger kids. And what are they reporting? So you can kind of look at these different segments. A fair number were writing down kind of family violence and abuse things. Some were talking about medical issues. Some were talking about accidents. I started to play with this word cloud, and it really actually started to highlight a few things for me. When you see some of the big words up there, these are the actual words that people wrote on the forms, the adolescents. Death and suicide were a big deal among these adolescents. It wasn't always that someone died by suicide, but it could have been a friend who attempted suicide. And then also thinking about parents, so moms and dads, and not just this idea that moms and dads hurt their kids, which unfortunately do sometimes happen, but how critical the experience of moms and dads are in general to the lives of adolescents who are, professing to be self-sufficient and independent and all the like. But describing how dad got sick or dad got hurt or mom died or mom had an illness, like really impactful things that oftentimes I think would kind of get a little brushed over. Not that it's not significant, but it wasn't the main focus of the visit. So when we looked at the actual symptoms, because this is just exposures, these were the actual symptoms. And I really want to focus, and I'm going to spend the last 4 minutes talking about these high trauma symptoms in adolescents. 8% screening, primary care, suburban primary care, like relatively low risk settings. 8% high risk for traumatic stress, high risk for PTSD in this group. This is not the child abuse clinic. This is a regular primary care setting. And you can see that it's very different than the CAC. So the red indicates high risk. That's the 8% in the primary care, whereas in the CAC, it's half of those kids. So that's really different. So I think you can make this argument that, okay, well, 8%, that probably is worth, considering screening. How does it compare to other things that we do or we might be considering doing on a relatively more frequent basis? And one of those things to think about is depression, because a lot of folks do screen for depression, either using a PHQ-2 or a PHQ-9. But I would make the argument that when you're screening for depression and trauma can be pretty tricky, especially if you don't know that the trauma is present. Because there's actually a lot of overlapping symptoms, and people with very good intentions can come in and say, I'm worried that my daughter or son is depressed. If you don't know about the trauma, you can't think about that cross-diagnostic overlap. And it makes a difference in terms of what we do. So if we're talking about bread and butter, pediatric depression, SSRIs, especially fluoxetine, is the most evidence-based treatment for depression in kids if you're using a medication. And therapies such as IPT and CBT, good, strong evidence base for moderate to severe depression in kids. So good evidence. We should do that if we find kids who are really depressed. If it's PTSD that we're talking about, SSRIs do not work for PTSD in kids, period. There is no strong evidence to support their use. In fact, there's 2 negative studies showing that SSRIs, frankly, might be more harmful than helpful in kids with PTSD. And therapy also that's not trauma-focused is not necessarily helpful. But things like trauma-focused therapies are helpful. So making a clinical decision now. And if we compare this head-to-head, so we actually had about 500 and some kids who completed both a PHQ and a UCLA. And again, those are the symptoms. So 5 times more likely to find a kid who's at risk for traumatic stress than you were a kid who's at a high symptom level for depression. So 1.7 versus 8.1. And if you plot them along a graph, these are the traumatic stress kiddos. So these are the kids that have a traumatic stress score of 20 or higher, highlighted in red here. And you can see this is the 8%. If you look at the kind of the modern high range, this is kind of like more like 6 or 7% of all the adolescents that were screened. So, a decent amount worth screening for, right? But if you start to look at the overlap, you start to see something that in a lot of these kids, if we just move forward with depression and not think about, well, is this better explained by something else? And not is it better explained by them having a low thyroid or something? But is it better explained by another equally common diagnostic morbidity such as trauma? There's a huge number of kids in there in that overlap. And really, there's more kids in the overlap than there are the pure, straightforward depressed kiddos. And if you look at the ones where we would more consider using a medication, again, there's more kids in the overlap than there are the ones where trauma isn't an issue. And just kind of to highlight this, so here's a PHQ that was filled out by a kiddo, and if you had a kiddo in your primary care clinic fill this out, no one would ever fault you for saying, it looks like they're depressed. They have also endorsed suicide. Let's consider starting fluoxetine and let's give them a referral to mental health. But if you go back to that initial case that we had at the very beginning, that the kiddo that kind of prompted us to say, how do we do this better? How do we do right by these kids? If you're capturing this kiddo with a PHQ-9 screener at this age, this is exactly how she would have responded. She would have scored high on the PHQ-9. But that wouldn't have told the whole story if you didn't also know about the sexual abuse. And so if you pair this, the PHQ-9, with then the back being the trauma screener, and as the clinician, you look at the two and say, okay, so yes, some depressive symptoms, but look at the trauma symptoms and look at the report of being raped and having that significant traumatic experience. What's the best thing for this kid? It isn't fluoxetine and a general mental health referral. The evidence is very clear that the best thing for this kid is a referral for evidence-based trauma treatment, which will, in due time, also take care of depressive symptoms as well, and do so in a much better way than any of the SSRIs are able to do. So that's, I hope that, I really appreciate the chance to talk with you all today. And I did want to try to stress a few things. And really, it's encapsulated this, that it's not that just trauma screening can be easy, but we have to have the right data available to us that for those patients where we need it, that 50% of the kids in a child abuse center or that 8% of the kids in a primary care setting, we need to know what's going on so we can make the right clinical decision. And it's not just identifying kids in need for trauma treatment, but really there's a lot of things to think about in terms of the other stuff we get referrals for. ADHD, anxiety, depression, where it might be that that's exactly what they have, but if we don't at least rule out trauma, we don't know for sure, where trauma can mimic or overlap a lot of those other common disorders as well. So again, thank you so much for getting up early and spending a couple of minutes with us. So.
Thank you so much. And we're going to be getting some questions, but quick question from myself is, have you had any feedback either from the adolescents who do the self-report or the families on what they think about being screened for trauma, especially since there may be surprises?
Yeah. So the feedback has generally been incredibly positive. We had a recent case in a child abuse center where mom was accused of abusing a younger child. Dad brought the kid in for the evaluation, and he read through the questions, and essentially we have a force, like you have to answer the trauma screening the symptom questions as well in a child abuse center because they're coming for a trauma. And he had an argument over the wording, basically saying, well, I don't think anything happened, so I don't want to fill out the rest of these questions. And for the staff, it was like, oh, well, what do we do? But as someone who's kind of hearing it, it's like, oh, well, just because you don't fill out the form in the way you intended doesn't mean you don't get an incredible amount of data from that family. And I think that spoke very highly to the concerns of the dad in that particular setting. But in general, I would say that, kids are waiting in the waiting room. It's a form to fill out. It takes just a couple minutes at the most, and then they're done. And I think that's been, the fact that it's short and quick, we've had very little pushback at all.
Thank you for an interesting talk. You did not mention the role of schools and teachers in, collaborating or cooperating in the treatment.
Correct. and they're incredibly important. And we're actually working with the Jordan School District and from some statewide approaches to think through how to deliver trauma-informed care within school systems and how to better collaborate. We're actually going to be sharing our model with them. Not that it's necessarily the best thing for them to use, because they need to be generalists and deal with lots of things, including trauma. But we do want to make sure that they have the same tools and capacities. And we have one county in Utah that I have to highlight, Iron County, middle of the state, not near much of anything. When they developed their trauma treatment program to go with the Children's Justice Center for the screening, they used the schools because their kids were at schools. They didn't have reliable community mental health programs, so they engaged with the school therapists and carved out some of their time to also deliver the trauma-focused therapy as well. And I think it was a wonderfully creative and salient type of response because it used the resources they had rather than trying to impose what we would do in Salt Lake. It's like, well, where are your strengths? And their strength was this school and this wonderful group of counselors at the school who do phenomenal work with these kids. And so let's utilize our strengths. So I think they're incredibly critical. And so I think it just highlights kind of how they need to be part of the discussion in terms of figuring out what's best for the kids.
Can you wait for the microphone? Bring it right down so people can hear your question.
I was wondering if you had identified any sort of stratification of the type of trauma versus the severity and longevity of the symptoms that people would experience afterwards.
The short answer is no. So we know that certain types of traumas are higher risk for PTSD. Sexually related traumas are higher risk than non-sexually related. Interpersonally related traumas are higher risk than more accidents. But in terms of the work we're doing, we really wanted to take more of an agnostic approach of, child reports exposure. We're not going to let exposure be the stratification tool. Rather, we're going to let the child's own symptoms be the stratification tool. But I think it's certainly a really important question to think about when you're balancing the exposure and the known symptoms, kind of highlighting, which kids are most in need of therapy. And I think that's where thinking about some types of experiences, even if there's more mild symptoms, clearly should push one into the kind of at least getting into the system for a trauma assessment.
You mentioned that there's a physiological base, it's my understanding, that's noradrenergic hyperactivity, and that there is some evidence for the use of guanfacine to help with symptoms. In fact, the problem that you noticed with the SSRIs, I did the last 8 years of my career on inpatient, and it's very common to have them on multiple trials of different SSRIs, failing, suicidal. And then if you actually move over to something that's noradrenergic, you can improve that a great deal. Because I think the comorbidity of suicide is the thing that is most worrisome. It poorly responds. The other thing that I had used experimentally based upon a lot of research is atomoxetine, the sister to fluoxetine, which is noradrenergic. And that is indicated for anxiety and ADHD, and also has some antidepressant properties, and should be good for PTSD and in some of the kids in the hospital at work. So this idea about can pediatricians do anything, Intuitive 10x guanfacine is something pediatricians use all the time for ADHD, and I think that might be helpful.
Yeah, so I appreciate the points, and just to highlight a couple of things. So in terms of that noradrenergic, and a lot of the literature talks about both noradrenergic dysregulation as well as HPA axis dysregulation and kind of the conflict of them not responding very well together. So that's a critical thing to understand. One of the things that we actually use a lot in our clinic is in addressing sleep, the use of alpha-1 blockers like prazosin to help with sleep. We've even published a little bit on that in terms of the safety and utility in kids. The main take-home message from a pediatric standpoint that I think is in contrast to the inpatient or child psychiatry perspective that I kind of also brought with me to this work is that in our setting where we're delivering evidence-based trauma treatment, I am the child psychiatrist for our group. We see over 500 kids a year for evidence-based trauma therapy. I see less than 10% of the kids because of how robust the response is to the psychosocial interventions like trauma-focused therapy. And that's the critical piece for me, because if we get them into the right treatment, the need for medication actually goes down significantly. And even things, so, I've certainly used guanfacine extended release or guanfacine immediate release with certain kids with a lot of that kind of hyperactivity, destructiveness. They're going to get thrown out of expelled from school type of kiddos. But one of the things that actually got highlighted in the one study that looked at guanfacine extended release is that even with an alpha-2 agonist like that, the nightmares didn't improve. And that's kind of what pushed me towards thinking more about addressing sleep through a behavioral sleep hygiene and occasionally the use of things like melatonin or prazosin or clonidine or guanfacine to kind of complement that, but not worrying about the daytime as much until we get the sleep under control. But when I'm thinking about the daytime, I tend not to use the guanfacine if I'm going to think about something like a medicine for sleep, because I don't want to use 2 blood pressure meds in a normotensive kid. And in that one study that there was, essentially those kids, the nightmares still didn't get better. And to me, that's a little puzzling, but also at the same time seems fairly consistent with the fact that the alpha-2 agonists have never had a robust treatment of PTSD. I think they're helpful, like as a piece of the puzzle, but there's a lot of evidence in the adult literature showing the robust nature of the alpha-1 blockers with those nighttime disturbances. And that combination of trauma therapy, which works for the great majority of kids, and then for that small group of kids needing some adjunct treatment, being thoughtful about kind of sleep-focused versus daytime-focused, I think is a critical decision. So, but thank you for that comment.
It's after 8:30. If you have any questions, feel free to come to the front.
What she said. Thank you. Slides are great. I love them.
Thank you.
Spent like 45 minutes. Like make an animating timeline. It has like 60 animations in it. Could be a bit crazy.
I have a friend of mine, Jeff, does the best slides.
You have been disconnected from the meeting.